It's recording him. It's
Good morning, everyone, and welcome to today's morning report. It's Wednesday, August 11th. We have two presentations today. We have two presentations today from 7 to 7:30. ITE Neurology by Dr. Tran. She already included some questions in her presentations. We have time, we'll do some mix-up. And at 8 o'clock, so from 8 to 9, we'll have nutrition by Ms. Starzon. So before starting, does anyone have any concerns on the floor? So before calling on Dr. Chan, we have an image challenge here. Who feels inspired? Can you see at the back?
No, not the question. Sorry.
Lens dislocation.
That's good.
Dr. Atem, will you please read the question?
A 60-year-old man presented to the emergency room with decreased vision in his right eye. 3 days after fall, examination showed abrasions on the right supraorbital area and forehead, pain with extraocular movement, and decreased right eye visual acuity. What is the diagnosis? I see the right lens is dislocated.
Everyone see that?
Yeah.
Yes. Okay, the majority of people answer the question saw that as well. Dr. Chan, I know you have a lot of time, so I will take some of your time, okay?
not really.
Paralyzed persons with anarthria, the loss of the ability to speak naturally, have difficulty operating assistive communication devices because their movement is severely impaired. Technology that can decode words and sentences directly from cerebral cortical activity may offer a way for such persons to communicate, which in turn could enhance autonomy and quality of life. This single participant study involved a cognitively intact 36-year-old man with severe spastic quadriparesis and anarthria caused by a brainstem stroke 16 years earlier. A high-density 128 electrode array was implanted in the participant's subdural space, where it acquired neural signals from cortical regions involved in speech processing as he attempted to speak. Recorded signals were transmitted to a real-time processing system via a detachable link. During 50 sessions over 81 weeks, the participant attempted to articulate individual words from a 50-word vocabulary, as well as sentences using those words. Machine learning and computational models were used to decode individual words from cortical activity patterns in real time, and natural language modeling was added to decode sentences. Outcomes included the word error rate and the number of words decoded per minute. During sentence decoding, a median of 15.2 words were decoded per minute. The median word error rate was 25.6%, which means that about 3 out of every 4 words were decoded successfully. The researchers note that speech decoding approaches generally become usable when the word error rate is below 30%. Signals recorded from the implant device were stable throughout the 81-week study period, enabling successful word decoding without requiring frequent model recalibration. The authors conclude that in a paralyzed person with anarthria caused by brainstem stroke, machine learning and natural language modeling were able to decode words and sentences in real time from cortical activity acquired via a neural implant during attempts to speak. They note that the cerebral cortex contained functional neural representations of speech, even after a prolonged period of paralytic anarthria. Full trial results are available at nejm.org.
So, is that being used? Does anyone know that is being used?
How much does it cost?
It's not yet. It's not yet feasible.
100,000?
Unfortunately, I don't know how much that costs. And the last thing I want to do before calling Dr. Chan, yesterday we talked about entering allergies. Let's say Dr. Robinson wants to enter allergies for this patient. Oh, can you see the back?
The part you want to show is better.
Wait a second, please. Is it better?
Yes.
So let's say you want to enter allergies for this. You want to enter allergies for this patient. Come here. Click on A. So enter new. See, there are no allergies here. Enter new. And then adverse reaction. So you type in whatever reaction the patient manifests. Why is that?
I think that's
So you type in the medication
that's the entire.
and then you give the reaction. What reaction? Is it rash or whatever? And then you go ahead and save. Is that clear? Yes.
Is it the same that the person used to do?
I didn't do anything here, so let's see. Okay, Dr. Chan.
Morning, everybody. Today I'm going to present a topic, neurology, to prepare for you the training exam. Very soon. And hopefully it's help you some. Can you hear me? we're going to talk about diagnosis of basilar anterior stroke, diagnose carotid artery dissection, diagnose vertebral artery dissection, diagnose cervical myelopathy, manage drug-induced encephalopathy, prevent migraine, treat Bell palsy, treat myasthenia gravis, treating relapsing remitting multiple sclerosis, and treat tension type headache. So question number 1, anybody want to read?
Specifically, our main possibility for right-sided facial pain times 6 hours. Patient reported pain is sharp, stabbing-like pain associated with hiccups, unable to free himself as he is right-handed. Past medical history stated anemia, hypertension, hyperlipidemia, medication-wise, simvastatin, aspirin, atenolol, and vital signs are with a normal and physical examination, dizziness and standing, horizontal and vertical misdiagnosis, ptosis on right eye, diminished gap reflex, loss of PMT on the right side of the face, pain and temperature on the right side of the face, and the left side of the body. What is the most likely diagnosis?
And what is most likely classification of injury? Right. So this patient present cross-sign symptoms suggesting a lesion of brainstem level, but which part of brainstem? That's the question. So let's review a little bit about the anatomy of the brain circulation. So the brain is supplied by the anterior circulation and posterior circulation. The anterior circulations arise from the two bilateral carotid artery. From carotid artery, it gives rise to ACA and MCA. In the posterior circulation, supplied by the blood from the two vertebral artery and then joined together to form the basilar artery and terminate into the two PCA. I think everybody very familiar with this image is step 1. So the brainstem is divided in 3 continuous parts: the midbrain, which is cut from here, and the pons and the medulla, except the cranial nerve number 1 and number 2 arise from the brain, parenchyma, and the cranial number 11 arise from the spinal cord. The left 9 cranial nerve arise from the brainstem. So the cranial nerve help you to localize the lesions. In this table, you can see that in the midbrain you have 2 cranial nerve, 3 and 4. In the pons, you have a medial in the cranial nerve 6. Lateral, you have a cranial nerve 5 and a 7 and 8. In the medulla, you have a cranial number 12 in the medial, and lateral, you have a number 9 and 10. So go back to the questions. So this patient presents with a crossing symptom. The cranial nerve is lateral with injury. So he have a right side facial pain. So the lesion will be the right side, and contralateral will be the left body weakness. The mean is Greg reflex. Greg reflex is combined of the cranial number 9 and number 10, which is the lateral of the medial medulla. So the lesion will be the lateral medulla. So why this patient have ptosis? Is that cranial number 3 injury? The answer is no. This is the Ordner syndrome. So the patient have a partial Ordner syndrome due to the sympathetic nerve travel along the tract. This is called Wallenberg syndrome. So the etiology of basilar artery stroke is like every stroke is including atherosclerosis, thromboembolism from the left vessel occlusion, or the heart emboli, or hypertension. Most common involved segment of basilar artery is the middle segment and proximal segment. So the case present, the patient have medial lateral medulla, so mostly involved to the posterior inferior cerebellar artery, which is pica. So the presentation, like I say, is usually a cross-sign symptom. The patient will have ipsilateral cranial nerve deficit combined with contralateral hemiparesis, sensory impairment, and sign symptom of brainstem, including nausea, dizziness, headache, confusion, vertigo, arthur, dysphagia, loss of consciousness, and respiratory cardiac compromise. In this case, we also see the Orner syndrome because of occlusion of the vertebral artery or the pica. So the patient will have ipsilateral ataxia and sensory loss over the face, ptosis, meiosis, and anhidrosis. There is another syndrome called top of bacillus syndrome, which is caused by occlusion of the tip of bacillus artery. Because tip of bacillus artery, come back to previous slide, you see the tip. This is the upper part, the distal part. So the granule number 3 and number 4 arise from upper part. So the patient will have oculomotor symptoms, pupillary abnormalities, bilateral vision loss, outer alertness, and behavioral or memories. So what is the next step in this patient? What are you going to do? If you have patient present with stroke sign symptom, what's the next step? Yeah, CT head without contrast. So the purpose of CT head without contrast is to rule out there's no hemorrhage. CT head without contrast is considered the best initial test. If the test is negative, then you do the CT neck and CT head to rule out is there any large vessel occlusion. MRA can be done for the CTA instead. Both CTA and MRA help visualize the cervical and cerebral vasculature, provide information regarding the degree of blockage, detecting arterial dissection. Most accurate test is the MRI. So you call when the patient have a stroke sign symptom, the ED will call stroke code, and then the neurology will be on board. They will recommend the MRI for the following day. But the first step will be the CT head without contrast. So if CT head without contrast, negative. So what is next? So in this figure, you will see the bacillus stroke of a lady 60 years on present with bacillus stroke sign symptoms. The figure A show you that's the occlusion of bacillus artery. These are the PCA, these are the MCA, and this is the ACA. This is posterior communicating artery. So you still see the circulation in the PCA despite occluded here in the bacillus artery because the posterior communication artery provide a good collateral supply for the PCA. In contrast, in this picture, you don't see the PCA vessel because completely occluded and a very poor collateral supply for the PCA. You can see a little bit here, so there's a collateral supply, but very poor anyway. Because the patient present with a bacillus posterior circulation, you also want to rule out several conditions, including hypoglycemia, intracranial hemorrhage, Meniere disease, multiple sclerosis, neuropathic disease, posterior reversible encephalopathy syndrome, sarcoidosis, seizure, sepsis, vestibular migraine, vestibular neuronitis, and West 9 encephalopathy. Most of the condition over here, I'm sure you guys know how to make diagnosis. I just want to talk a little bit about these two conditions, neuropathic disease. Neuropathic disease basically just pathic disease combined with a neurologic deficit. the patient will present with a lesion ulcer in the male genital ulcer and neurologic deficit. It can be focal or it can be diffuse. In the posterior reversible encephalopathy syndrome, this is a picture of the posterior reversible encephalopathy syndrome. You will see the abnormalities. It's best seen on the MRI. You will see the abnormalities of the white matter at the watershed area between the occipital lobe and the parietal lobe. Why the patient have a posterior reversible encephalopathy, patient will come with the urgent, sudden onset sign symptom of neurologic deficit. Usually happen the patient hypertension, the same as stroke, but most likely occur in the patient taking chemotherapy, cisplatin, cyclophosphamide, etc., tacrolimus. Now question number 2. Anybody want to give?
A 73-year-old for left-sided weakness that started 1 hour ago. Her daughter reported patients dropped her fork while having dinner. Then she was unable to walk to bed. Past medical history: hypertension, hyperlipidemia, diabetes mellitus. Physical exam: normal S1 and S2, no carotid bruise, dense left-sided hemiplegia. Workup: non-contrast CT head is negative for hemorrhage. CT angio head and neck is negative for
Left vessel occlusion.
left
So-
vessels occlusions. Questions: what is the next step in management?
Yeah. So what you're going to do after you get a CT head, you get a CTA, what's the next step? So the purpose of the CT to rule out hemorrhage. So when the patient doesn't have hemorrhage, and the next question you will ask, when the symptom occurs, is it still within a 3 to 4.5 hours? So you can treat the patient, right? The next question is, when was the last time the patient was seen well? This patient present with a symptom an hour ago, so the symptoms still in the window for treatment. So the next step, what would you give the patient? TBA, perfect. We're going to give the patient recombinant TBA. What if the symptom occur after the window, outside the window period? What are you going to give the patient? You give the patient aspirin, high dose, 325 milligram PO. So, but before you give that, you have to accept bedside swallowing dysphagia. Otherwise, the patient will choking, aspiration, etc. So the management for ischemic stroke, we asked the last time the patient was seen well. So if within the window 3 to 4.5 hours, you give the IV TBA. Usually it be given within 60 minutes arrival of the ED. Outside window, you give the aspirin high dose. If the CTA show left vessel occlusion, you will call the IR for the mechanical thrombectomy. Will you give the TBA though while waiting for the thrombectomy? Some people will say yes, some people will say no. So that depends on the IR and the neurology discussion. But definitely the patient will need the thrombectomy. So continue the question. So recombinant TBA is given 7 hours later. Her left side weakness is improved, and you recheck the vitals because you have to monitor the stroke patient blood pressure every 2 hours. So when you check the blood pressure, you see the blood pressure is 198/110, heart rate is 87, regular rhythm. So what is the next step in management? What are you going to do for the patient? So you want to control the blood pressure, right? You will give the patient IV medication, labetalol or hyranazine. So after you give the patient TBA or thrombectomy, you have to admit the patient to MICU. When a patient admit to MICU, there's two there's two management important. First is that you have to control the blood pressure. Before the TBA, you don't have to give the blood pressure medication control if the blood pressure under 185/100. 110. But after the TPA, the blood pressure should be lower a little bit, 180 over 105. If higher than the goal target, you have to give the IV labetalol or licardin before the TPA. And how about antiplatelet, anticoagulation? The first 24 hours after the TPA or thrombectomy, you will hold any antiplatelet or anticoagulation, the patient taking it home. After 24 hours, you will start the antiplatelet. Why? To prevent another stroke. And when you start the anticoagulation for DVT prophylaxis, after 48 hours, if you repeat the CT head negative. Some patients come, they have an AFib, so they on anticoagulation, for example, Eliquis. So for these patients, you don't start anything. You just continue Eliquis and put the patient SCD in addition to the anticoagulation Eliquis. If the patient not on any anticoagulation, the patient didn't get TPA on admission, the patient not on dual antiplatelet therapy, then you start the heparin 5,000 BID sub-Q. For the hemorrhagic stroke, the goal is to prevent another hematoma expansion. So the target for the blood pressure is blood pressure should be even lower, around 140. If the blood pressure more than 180, then you the same, like ischemic stroke, you give IV labetalol hydralazine. Don't give nitroglycerin or nitropruxide because it will rebound increase intracranial pressure and it further reduce the blood supply for ischemic reason. So hemorrhagic stroke, you will see obvious on the CT scan, right? So what you're going to do besides you control the blood pressure, you have to stop all anticoagulation, antiplatelet agents. Patient on dual antiplatelet therapy, hold that. Patient are Eliquis, hold that. So do you have to reverse the anticoagulation though? Yes. If the PTT is more than 2 upper normal limit, you have to give fresh frozen plasma. If the INR abnormal in the patient with warfarin, taking warfarin, and patient come with a supratherapeutic therapy, so you have to reverse with the vitamin K or BCC. In addition, in MICU, sometimes Dr. can give the hypertonic saline 3% or the mannitol recommended by neurosurgery. If the patient have hydrocephalus or hydrocephalus impairments or status seen on the CT, then you consider ventricular drainage. If cerebellar hemorrhage more than 3 centimeters in diameter, that is the indication for core neurosurgery for evacuation to prevent the brainstem compression and herniation. So we move to the question number 3. Anybody?
Severe headache localized to the left frontal temporal region that started chloride syndrome, associated with visual impairment on the left eye, which now visible. Patient reported no previously similar symptoms. Meds as in to arthritis type 2 diabetes. Vital signs are 98.1, blood pressure 150 over 96, and heart rate of 89 beats per minute. Physical examination, left eye, thoracic, and meniscus. Workup hemoglobin of 13.2, platelet count 200,000, WBC 6K, ESR 15, and the CT without negative.
CT negative.
Yeah.
So what do you think this elderly man, he have a sign symptom? Stroke, right? Look like stroke.
Is it TA?
You think he have a TAA?
The diagnosis of TIA is actually changed. It's not, you don't still rely only on the resolution of the symptoms. You also have imaging which has to support the resolution of the symptoms.
So this patient, if the TAA, the patient will not have eyes findings, no. This patient, when you do physical exam, you see the patient have ptosis, meiosis, Ascari syndrome, right? So look like he have something wrong with his neck. carotid artery dissection. So the next step, you will do the CT head and CT leg. Dissection of cervical vessel. So cervical vessel divided into the carotid artery dissection or vertebral artery dissection. Usually, patient present with acute unilateral head and neck pain. If the carotid artery dissection, the patient will have partial ulnar syndrome. Like in this case, the patient will have ptosis, meiosis, no anhyrosis, and ipsilateral signs of cerebral or retinal ischemia. In contrast, if the patient have vertebral artery dissection, the patient will present with posterior circulation, occipital headache, neck pain, posterior fossa syndrome, including cranial nerve number 10, dysphagia with arthur, ataxia, and hemifield visual loss. So the risk factor for the cervical vessel dissection, including hypertension. If a young patient usually come with a migraine, polycystic kidney disease, connective tissue disorder, or even spontaneous or after trauma, or neck manipulations. So the best initial test for cervical artery dissection is the same. CT head without contrast. CTA and MRA head and neck. The most accurate test is the MRI or catheter angiogram. In these tests, you will see a tapered arterial lumen or increased arterial diameter with intramural hematoma. So the management for several artery dissection, the same like ischemic stroke management. You give a TPA if the sign symptom within the window 3 to 4.5 hours. After 24-hour TPA, then you start antiplatelet and anticoagulation after 48 hours. This figure, the top left show you the CTA of the neck. The white arrow point to the aneurysm of the ICA, internal carotid artery. And this is the MRI of the neck. You will see the crescent shape of the hematoma within the lumen of the ICA. The bottom is the dog-leg ultrasound of the carotid artery. You will see the turbulence flow and accelerate systolic and diastolic velocity. Question number 4.
A 50-year-old male presented to the ED for 3 weeks history of worsening pain in middle back and 2-day history of increasing leg weakness that has made ambulation difficult. Past medical history: metastatic prostate cancer treated with leoprolide, visual within normal limit, physical exam, muscle strength showed 4/5 weakness and hip flexor. Reflexes are 3+ in both legs. And QT, what's the next step in management?
So what do you think this patient have? What is the most likely diagnosis? Look like spinal cord compression, right? Spinal cord compression. So what are you going to do? You want to make sure this is spinal cord compression because this is the neuro surgery emergency. So you want to get the MRI of the thoracic spine. Myelopathy, which is any disorder involved with spinal cord. You give steroid, right? On, okay. You will scan neck to the neck, cervical, thoracic, and so myelopathy is a disorder involving to spinal cord. It can be compression or non-compression myelopathy. It can be, the reason can be extrinsic or the intrinsic. Patient in compressive myelopathy, they usually present with a neck pain, back pain, weakness, sensory changes, and incontinence, bladder, bowel dysfunction, upper motor neuron size and symptoms: spasticity, hyperreflexes, or lower motor neuron cell size, atrophy, hyporeflexia. So the sign symptom when the patient presents will help you to think about what is the reason the patient have a spinal cord compression. If the patient comes with a fever, tenderness, and recent use any instrumentation, IV drip user, or the patient have a sciatica, and she or he go to see the doctor and they inject the steroid, the patient can have a spinal cord compression, epidural abscess. A history of cancer, for example, in this case, the patient have a prostate cancer and come with a back pain with the sign symptom of spinal cord compression, usually due to metastatic disease or the pathologic vertebral fracture. Or the patient on anticoagulation did the monitor with the primary care doctor, the patient can have a spinal cord compression due to epidural hematoma. So best initial test is the MRI spinal cord cervical, thoracic, and lumbar. Most accurate test is the CT myelogram. When you do that, when the patient is contraindicated to the MRI, for example, patient have a pacemaker not compatible with the MRI machine, the patient have metabolic foreign body in the eyes, or the patient have end-stage renal disease. Patient have AKI and too high creatinine, for example, 2.4, 2.5 something. You don't want to put the patient on the MRI. But if the patient end-stage renal disease, you do it anyway because the patient will go to hemodialysis. So you do the MRI of the thoracic spine and you see a contrast enhanced mass originating in the T8 vertebral body with invasion into the epidural space that causes moderate cord compression. What's the next step? What are you going to do? So you confirm spinal cord compression, and this is emergent in the neurosurgery. So you have to give a high dose steroid. So we're going to give the patient dexamethasone at 20 milligram IV push. I remember last time Dr. Fanoyam said he would give 50. Dr. Varela, he said it range from 5 to 100 milligram IV push. I see Dr. Ashula, she give 10 from beginning and then just follow up maintenance dose until the patient is seen by the neurosurgery. For definite treatment is the surgical decompression plus radiation in this case because the patient has metastatic cancer. So the management, you give hydromethylene prednisolone and you treat for underlying causes. If the patient just have a trauma, herniated disc, hematoma, just a surgical decompression. In this case, the patient have tumor, so in addition to surgical decompression, the patient should undergo radiation. Now we talk about the topic of management of drug-induced encephalopathy. Encephalopathy, which is the alteration in mental status in which normal function of the brain is disturbed temporarily or permanently. Patients usually present with mental status. On the exam, you see impaired attention, memory, disturbed sleep, awake cycle, decreased alertness, hypervigilance, hallucination, disorientation. The patient can present with a seizure. On the cranial nerve exam, you will see ocular motility remain intact. However, other brainstem reflex affected in the severe cases. Motor exam, patient can present with a tremor, asteresis, for example, it's like a hepatic encephalopathy, multifocal myoclonus, and increased deep tendon reflex. On the cardiopulmonary exam, you will see the autonomic instability, including tachycardia, hypertension, fever, and diaphoresis. So, what are the drugs can induce encephalopathy? Usually, it can be from the prescription medication, opioid, sedative, hypnotic, Ativan, antipsychotic, haloperidol, lithium, skeletal, muscle relaxation, polypharmacy. Patient take multiple medication at once. Or non-prescription medication for a patient taking too much antihistamine seasonal allergic, the patient just go to the CVS, buy over the counter, and then continue to take the medication. Or can be medication side effect. For example, hyperammonia from the valeric acid, confusion from quinolone or serotonin syndrome. So what you going to do when you suspect the patient have a drug-induced encephalopathy? First, you have to review all medication lists and discontinue all the medication that you think can contribute to the patient's signs and symptoms. Then you restrain the patient only is it the last resort. You don't want to restrain the patient because it's usually cause the patient more agitated. In the case of severe agitation, you can give the haloperidol IV or IM. On the patient, you usually give very small dose, 0.5 BID. And pay attention, if you give haloperidol, just monitor the EKG to prevent the PTC prolongation. And if the patient already on benzo, patient undergoing alcohol and or benzodiazepine withdrawal or on anticholic toxicity, Parkinsonism, you don't want to give haloperidol. So question number 5.
24 years old female has 4-year history of monthly headache. The pain is bitemporal throbbing, worsened by bending, climbing stair, associated with nausea, benign photophobia, phonophobia, visual changes, neurologic symptoms. Over last year, the headache had not changed in character but gradually become more frequent from 4 to 10 days per month. Each episode lasts 8 hours and responded to ibuprofen within 1 hour. Medications, no other home medications, vitals within normal limit, physical examinations unremarkable. Question: what is the next step in management?
So what does this patient have? So whenever you encounter a case of headache, you want to rule out this is a primary headache or secondary cause of headache. You want to rule out secondary cause because stroke, suprarachnoid hemorrhage, tumor, those are the critical things you want to rule out. A patient have those. Then you think about primary headache, including tension headache, cluster headache, and migraine headache, right? So this young female look like she have tension or migraine. She have a migraine because you don't have a increased episode of headache, intention headache. So this patient have a tension headache. What is the next step you're going to do? You give metoprolol. So under acute headache is managed with ibuprofen. She have no complaint. But however, her episode of headache keep increasing, which means you have to put her in prophylaxis to prevent migraine. So indication for preventive treatment of episodic migraine in adult, whoever have a frequent long-lasting headache, for example, 5 headache per month, or the headache lasts more than 12 hours per day, and migraine attack can cause significant disability or diminished quality of life despite appropriate acute treatment, or menstrual migraine, or the patient, or just to give the medication to prevent the risk of neurologic damage or impairment in the presence of uncommon migraine conditions such as hemiplegic migraine or migraine with brainstem aura and prolonged aura. So you can give medication. There's a lot of options in medication. You can give beta blocker, metoprolol, propranolol, timolol, antidepressant, TCA, venlafaxine, anti-epileptic, valeric acid, topiramate, or you can give a new medication is a calcitonin-related peptide antagonist. The drug of choice is the first 3 options: beta blocker, antidepressant, anticonvulsant. But which one you would choose? It's the same like you control the heart rate in the AFib. You would choose a medication based on the underlying medical condition. For example, if the patient hypertension smoker under 60, you will choose a metoprolol, propranolol, timolol. If the patient hypertension smoker more than 60, you will choose a verapamil. If the patient had depression, mood disorder, you would give a TCA, amitriptyline, venlafaxine, antidepressant. If the patient have underlying epilepsy, you will give an anti-seizure, valproic acid, topiramate. If the patient has insomnia, you give TCA. Obesity, you give topiramate. And renal phenomenon, you give a calcium channel blocker. Also, it's important to note that valproic acid is contraindication for childbearing female because it's a teratogenicity. So there's another option also for prevention migraine. It's called a non-pharmacologic intervention. Encourage the patient to do aerobic exercise, biofeedback, relaxation training, cognitive behavioral therapy, acupuncture, etc. Now, question number 6. Sometimes you just look at the picture, you know what they're going to ask. Physical exam is seen in the picture. You tell the patient raise the eyebrow. The patient can do it on the right side, but he unable to do the left side, right? So look like have a Bell palsy. Bell palsy, what are you going to give the patient? You will give a steroid, right? Prednisone pill. So Bell palsy can be idiopathic or secondary, usually combined disease, sarcoidosis, HIV, vasculitis. If the patient can raise the eyebrow, but can drooping on the corner of the mouth, that is serious. You have to do MRI because you want to rule out the central facial weakness, which is stroke. You have to do the MRI. So it's the same like we say the patient have eyebrow sagging and able to close the eye completely, disappearance of the nasolabial form on the affected sides and decrease the tearing, hyperacusis, lost taste sensation in anterior tooth terraton. Diagnosis, usually clinical diagnosis. For the treatment, you will give the patient 10 days of oral prednisone, okay? And start within 3 days of symptom onset. You give the patient antiviral treatment, is not shown any clear benefit. However, pay attention, we also have to protect the eye because the patient cannot close the eye completely, so you provide an eye patch and artificial tear to prevent corneal dryness. 7 to 90% patient will fully recover within few weeks. If not, you have to get a brain MRI. Question number 7. This is a very easy question.
A 71-year-old female is evaluated for difficulty holding her head upright. She notes that her head feels heavy and reports intermittent difficulty of swallowing and speech worse in the evening. Denied pain, sensory changes, weakness in extremities, cognitive or behavioral symptoms. Past medical history is unremarkable, no medications, physical examination, vital signs are stable, speech is dysarthric, cervical extension is weak, no ptosis, ophthalmoplegia, sensory deficit or weakness. Labs, normal CK, no acetylcholine receptor antibody are detected. EMG of the limbs are unremarkable, but a repetitive stimulation protocol shows a decremental response. MRI brain is normal. Question, what is the most likely diagnosis?
C? B. 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 Okay, B, correct. So the patient unlikely have multiple sclerosis, right? She should have another focal neurologic deficit. The patient unlikely have myositis, CK, because her CK is normal. So mostly diagnosis in myasthenia gravis crisis. The key phrases here is the symptom worse in the evening, and when you do the EMG, it shows the decremental response. Pathology, you know, this is autoimmune disease, antibody attack the neuromuscular junction, and usually by model distribution, young female or middle-aged male. Clinical diagnosis for myasthenia gravis crisis. You can check the acetylcholine receptor antibody. If negative in this case, the next step is you obtain the muscular specific kinase antibody. Usually patient complain weakness of cervical extension. More cycle test is the EMG, and you want to do the chest X-ray or CT chest rule out thymoma. So the treatment is cholinesterase inhibitor, pyridostigmine, neostigmine. If more than 60, you want to give the immunosuppressive therapy, steroid, azathioprine, mycophenolate mofetil, cyclophosphamide. If the patient have a myasthenia gravis crisis, patient come with acute respiratory distress, trend-like weakness, you want to aggressive treatment with IVIG or plasmapheresis, and then continue with a steroid. And the thymectomy if confirmed thymoma on the imaging study. So this is the question number 8.
The 22 years old female came to her B&B for intermittent dizziness, weakness, unsteady gait for a few weeks. She also reported visual loss and eye pain, worsens with eye movement for 3 days. A year ago, she had tingling and numbness in her right hand associated with unsteady gait, which resolved spontaneously after a few days. Has medical history none, not taking any medication. Physical exam, vital signs stable, right eye, diminished visual acuity, and an afferent defect. Right arm tremor, both legs asthmatic. Both spastic paresis, hyperreflexia, and a positive Babinski sign. What is the next step in that?
So what does this lady have? What is the most likely diagnosis? You have a eye symptom, sensory motor symptom here and there, mostly diagnosis multiple sclerosis, right? So you want to confirm this is multiple sclerosis, you will do the MRI of the brain. You don't want to do a puncture, there's no sign symptom infection. You don't want to do CT head because this is long history. Doesn't show any specific stroke sign symptom. She doesn't have risk factor for stroke. This is autoimmune disease attack the neuron of the brain, spinal cord, and optic nerve. So the patient present with eye symptom, visual deficit, eye pain with eye movement, spinal cord, sensory motor deficit, below the affect spinal level, and also have incontinent urinary bowel bladder incontinence. So the diagnosis is best test with MRI. If MRI equivocal, you will do lumbar puncture and you will see the oligoclonal band IgG elevation. So MRI confirms she have multiple sclerosis. What are you going to do next? She in acute exacerbation, right? You want to uphold the symptoms with IV steroid, right? Methylprednisolone. So the treatment for acute symptom in high dose steroid, you give 1 gram IV for 5 days, follow up with a PO medication 1,250 milligrams for 5 days. And then you can get the no corticotropin gel intramuscular. If not respond with steroid, you can put the patient on plasmapheresis for 5 times, 5 days. The patient improves symptoms significantly. Now she's ready to go home. What you going to give her, send her home with what? You want to prevent another episode of myasthenia gravis crisis. So the drug of choice would be beta interferon, okay? Rivastigmine for the dementia, topiramate for the migraine headache, and VO you don't. It's not worth for either acute or prevention. So prevent myasthenia gravis, multiple sclerosis relapse. So you can use clothianide, interferon beta, or etc. And if the patient has symptomatic symptom, you can give for specific of any complaint. For example, urinary incontinence, you give oxybutynin. In addition to that, you encourage the patient have a lifestyle modification, exercise. Question 9.
So we will have to.
What's the 9?
Yeah. Let's take a 5 minutes
Okay.
break.
Okay, thank you.
That was the last objective tension type.
Christine?